All right, so let's get started. So I'm Mark Albert. Welcome everyone to the April ASJ Journal Club presented by the Young Aesthetic Plastic Surgeons Committee. Tonight we'll be discussing the article entitled A Practical Guide to Managing Patients with Systemic Symptoms and Breast Implants. So 2 reminders before we begin. Number 1, please mute your microphone. And number 2, if you have a question, feel free to ask it in the chat box anytime, or at the end, feel free to turn on your video and ask a question or make a comment. So tonight I'm joined by Dr. Janice Sarhadi. She'll be presenting poll questions to you, and she'll also relay your questions from the chat box to our speakers at the end of the night. So tonight I'm going to begin by introducing everyone, and then Dr. McGuire will then tell us about her article, followed by commentary by our 2 discussants. So our author tonight is Dr. Pat McGuire. She is a native of St. Louis, Missouri, and attended medical school at the University of Missouri, Kansas City. She did general surgery at WashU and plastic surgery at St. Louis University. She's currently a clinical instructor of surgery at WashU and has been in private practice with Park Crest Plastic Surgery since 1991. She was past president of the St. Louis Area Society of Plastic Surgeons. She's a traveling professor for the Aesthetic Society, vice chair of the Aesthetic Society Breast Implant Illness Task Force, chair of the Aesthetic Society Ethics Committee, member of the ASPS ALCL Patient Safety Committee, member of the quote Ask an Expert unquote panel for breast implants for ASPS, and she's a board member of ASERF as well as an editorial board member for ASJ. She is a principal investigator for the ASERF sponsored study entitled Systemic Symptoms Biospecimen Analysis Study, which is the first prospective blinded study of patients with self-described breast implant illness and control groups. So Dr. McGuire, thank you so much for being with us tonight.
Thanks, Mark.
Our first discussant tonight will be Dr. Dennis Hammond. Dr. Hammond attended the University of Michigan, both for undergrad and medical school, before integrated plastic surgery training in Grand Rapids. He then completed 2 one-year-long fellowships in hand at Medical College of Wisconsin, and then aesthetic and reconstructive breast surgery in Nashville under the direction of Drs. Pat Maxwell and Jack Fisher. Dr. Hammond is one of the world's most recognized and respected authorities in aesthetic and reconstructive surgery of the breast. He has co-edited one of the most influential textbooks in plastic surgery, along with Dr. Scott Spear. In addition, he has authored numerous book chapters concerning breast-related topics in nearly every respected plastic surgery textbook currently in use. He has now also written his own single-author textbook entitled Atlas of Aesthetic Breast Surgery, which was first published in 2009. He has authored many scientific papers and serves as a reviewer for 3 journals. Dr. Hammond has provided live surgery at various meetings all over the world, including Baker Gordon, Atlanta Breast Symposium, and others. He's given hundreds of presentations at meetings all over the globe, and he has served as the chairman of Santa Fe Breast and Body Contouring Symposium twice, most recently in 2011. Dr. Hammond has also developed his own tissue expander for breast reconstruction, as well as the internationally utilized Body Logic evaluation system used for implant sizing and breast augmentation. He's participated in nearly every known breast implant study since 1990, and he's also developed the spare mammoplasty technique for reduction of large breasts with half the usual scarring. So thank you very much, Dr. Hammond, for joining us tonight.
Thank you.
And our second discussant is Dr. Brad Calabrese. Dr. Calabrese is a graduate of Indiana University Medical School and completed residencies in both general surgery and plastic surgery at the University of Southern California, Los Angeles. He then completed a cosmetic and breast surgery fellowship, also with Pat Maxwell, and began practice in Louisville, Kentucky in 1997. He has dual clinical faculty appointments at the University of Louisville and University of Kentucky, and received teaching honors in 2007, 2011, 2014, 2015, 2016, and 2019. Dr. Calabrese also is the director of his Aesthetic Surgery Fellowship, which is endorsed by the Aesthetic Society. Dr. Calabrese is also an internationally recognized leader in aesthetic breast surgery, and he's participated in multiple FDA clinical breast studies and has been a consultant and speaker for Allergan, Mentor, Galatea, Evolus, Revance, and Sientra. He also performed live surgery at multiple times at the Atlanta Breast Symposium, as well as the Advanced Aesthetics meeting in St. Petersburg, Russia, and the ISAPS meeting in Vienna, Austria in 2021. He co-authored the 10-year clinical FDA trials for Sientra and Mentor. Recently, his publication in the Aesthetic Surgery Journal entitled the safety of smooth and textured silicone breast implants, was the recipient of the Best Journal Article Paper Award for ASJ in 2018. Dr. Calabrese also received the prestigious Aesthetic Society 2018 Scott Spears Award for Best Lecture on Breast Surgery. In 2020, he published a textbook on augmentation mastopexy and a video series on options in mastopexy with QMP Publishing. He's a traveling professor for the Aesthetic Society, and he also co-chairs the Aesthetic Training Program Committee and the Breast Emergency Response Work Group Committee for the Aesthetic Society. He is also a clinical editor for the Aesthetic Surgery Journal. So thank you, Dr. Calabrese, for also being here tonight.
Yeah, thanks, Mark.
All right, so let's get started. At this point, we'll turn it over to Dr. McGuire to share her screen and to discuss her article. Thank you.
Thanks, Mark. Thank you all for attending. Here are my disclosures. So I appreciate the ASJ using our paper for Journal Club tonight. Practical Guide to Managing Patients with Systemic Symptoms and Breast Implants. We decided to write this paper after having patients come in requesting implant removal for a variety of systemic symptoms, many of whom are appropriately worked up, but there have some who have not been that we see. I had a patient come in very symptomatic and had not had an appropriate workup. I drew some labs on her. She had an elevated calcium level, sent her back to her internist who found out she had hyperparathyroidism, and all of her symptoms resolved after treatment of that without removing her implants. Mindy Hawes, one of my co-authors, had a patient come in 2 years after breast augmentation with very significant symptoms. And Mindy said, patient looked sick, abdominal pain, weight loss, fatigue. She sent the patient back to her internist, and this patient ended up having metastatic liver cancer. So you don't want to miss something on these patients. We want to make sure that they have an appropriate workup. So this all starts even before patients have implants. On all of my new breast augmentation patients or breast reconstruction patients, you have to discuss the risk of implants. I was at the FDA device hearings in March of 2019, where one of the recurring themes we heard from the breast implant illness women who were testifying is they didn't feel like they were given appropriate risk information. So capsular contracture, rupture, implant malposition, the fact that they'll need implant surgery. And also I specifically tell patients that there are patients with systemic symptoms they attribute to their implants and use the term breast implant illness. Surprising to me how many of them already know about it. They say, oh yeah, my friend had it or someone else, and they're still coming in for implants. Just want to make sure they all understand that. And then talking points to patients. I tell them, there are patients with implants that report symptoms. We don't have any scientific evidence of causation, but there have been some papers that suggest a potential association. And that some patients do report symptom improvement after implant removal, and we're still studying this. One of the other authors of this paper was Dr. Dan Klaub, who is a rheumatologist at the University of Michigan. He's an expert on fibromyalgia and overlapping pain syndromes. And so these are the considerations that he contributed to the discussion. Is that these patients, the breast implant illness patients, are very similar to those of other overlapping pain syndromes: fibromyalgia, chronic fatigue syndrome, Gulf War syndrome, sick building syndrome. And patients with these conditions may experience stigma, and they feel abandoned by their physician and healthcare system because they've been written off a lot of times as crazy. They're frightened because they have real symptoms and no one can give them a diagnosis. The symptoms should not be trivialized, and they require a full medical workup. And again, the recurring theme is they feel like they had not been forewarned about the potential risk of implants, and they turn to social media for their main source of medical information. So how do you assess these patients? Well, history, physical exam, review their previous laboratory and radiology results, and really look at them. Some of these patients come in with like encyclopedias, but a lot of kind of kooky stuff. So you want to make sure they've had an appropriate medical workup by a licensed medical practitioner. And then discuss with them the options for further investigation: CBC, CRP, SED rate, electrolytes, creatinine, thyroid function, vitamin D, calcium levels. Breast implant illness has no specific diagnostic criteria. It's a diagnosis of exclusion. So you want to just tell the patients, we don't want to miss anything. And then you have to decide for yourself, are you comfortable performing the workup? Are you going to refer them to the appropriate specialist? Most common symptoms in the workup that we talk, I'll briefly go through this. For fatigue, there's a lot of different causes: anemia, cardiac, thyroid, lifestyle, hormonal, medications, depression, anxiety. So for that, make sure they're not anemic. Check the thyroid function, liver, kidney function, and EKG, vitamin D levels. 40% of the population has low vitamin D levels, and many of those symptoms are similar to what we hear in our breast implant illness patients. Brain fog is the ability to think clearly, concentrate, or have memory issues. That could be from sleep disorders, a TIA, dementia, medication, mood disorders. I consider referring them to a neurologist if they have nystagmus, tremor, or gait abnormalities, or anything that just doesn't seem right. Anxiety is a common one. Do they have an underlying mood disorder? And then consider screening for their surveys for anxiety and depression. And a lot of these patients have implant concerns, or especially those with textured implants, that may be from having a textured implant, worried about ALCL. For GI symptoms, history, any dietary change, lactose intolerance, celiac disease, these patients probably should be referred to a gastroenterologist for evaluation. Joint pain is by history and physical exam. Trauma, gout, infection, tumor, any acute symptoms, or if they can't bear weight, those patients need to go for urgent evaluation. And then hair loss, do they have a family history of it, and thyroid issues. This was a table from the paper with the recommended laboratory and the appropriate specialist. Then let's say you work these patients up, they don't have any medical issue, they have a right to have their implants removed. And there is evidence that some patients will experience symptom improvement after explant. The paper that we published in ASJ in December on the first round, the first paper from our study, we did show that 94% of the patients had at least some symptom improvement through 6 months follow-up. But also tell that the type of capsulectomy does not influence symptom relief. And we know that from this paper. This was a prospective blinded study with control groups. We had followed these patients. We did a symptom survey and NIH validated patient reported outcome measure before 3 to 6 weeks, 6 months, and 1 year post-op. And we had at 6 months, 98% follow-up in the BII cohort. We're at 1 year, we're at 90% follow-up. And these patients did have symptom improvement. There was a 68% reduction in symptoms 6 months post-op. And these seem to be holding, there's some drop off of symptom improvement at 1 year, but most of them remain improved. But that symptom relief was independent of the type of capsulectomy, whether it was a total capsulectomy, a partial capsulectomy, or an intact total, what the patients referred to as an en bloc capsulectomy. And I think that's important to emphasize with those patients. So in conclusion, these patients have real symptoms. You have to show them compassion. They have no diagnosis has been made. You should make sure they have an appropriate preoperative workup, and they have a right to have their implants removed. But we have no scientific evidence that a total capsulectomy is indicated on these patients. And many of these patients will have symptom improvement, but there is no guarantee. And then prior to implant surgery, any implant surgery, make sure they're educated on the risk involved with implants. Thank you.
Thank you very much, Dr. McGuire. I look forward to hearing more from you in a little bit. In the meantime, if you don't mind, Dr. Hammond, we'll turn it over to you for your comments.
This is just really critical work that's been done by Pat, and I can't think of somebody better to do it than her and her partner in crime, Caroline Glixman. I think together they have both just made a tremendous inroads in this, because all of us are faced with these kinds of patients on a daily basis. And it has been a conundrum over the years, going all the way back to the original silicone scare back in the 90s. And so I think what we're starting to do now is gather the scientific data that we need to adequately counsel our patients. And Pat's touched on all of the important issues. The thing that I took away from the paper was really the discussion with regards to capsulectomy. Now, that is really one of the big issues that I struggle with in my own practice, because when there's a reason to do a capsulectomy, and they pointed this out in the paper, there's capsule contracture or there's some sort of shape problem, it's fairly easy to justify taking the capsule out. But I'll paint the worst case scenario, an otherwise asymptomatic, aesthetically pleasing saline breast dog that capsule is going to be paper thin. And it really becomes almost harmful, really, to try to take a capsule out in somebody like that, especially when it's against the chest wall and you really can risk getting into the pulmonary space. So we've got to come to some kind of a consensus and have some data that allows us to say, no, I'm so sorry. I'm not going to take out that posterior capsule if I think that it's dangerous. And that's where this data that I think Pat and Caroline and others are starting to accumulate is really going to be helpful to us.
Thank you, Dr. Hammond. Dr. Calabrese.
Thank you. Yeah, so I've been following Pat and Caroline's work right all along the way, and we were part of, the BBII task force as part of the Aesthetic Society, and then also we're at the panel back in 2019 when really this ramped up. So we were so excited. This was ASERF sponsored, granted studies. They've got multiple papers coming out. They just had another one, I think, accepted to the journal as it relates to the metals, et cetera, in the capsules. So as Dennis said, this is extremely important because we need some guidance because we're trying to be doctors and good doctors to our patients. And we're doing it kind of blindly. And I think that's what this paper, what this was for all of those who aren't sitting at the table talking about this all the time, to have an article in our journal that kind of reviews where we are with it, what we know, what you should be thinking about when you see those patients. And it's not always obvious when a patient comes in wanting her capsule removed and her implants removed to think about and they have all this myriad of symptoms, over 50 symptoms possible, that there could be real causes to those. And it's a real miss if you don't at least consider those and make sure they're having a full evaluation, an autoimmune evaluation, they need one, and always looking for GI symptoms and root causes and what's their anxiety disorder. And I think that's what this paper tells us all, to remind us that we have to still treat them as a physician and do that. The last thing I'll say about this as it relates to this is it wasn't that long ago at one of our journal clubs here in Louisville when this subject came up, and the consensus in that room was that somehow it is crazy to even listen to these patients about these symptoms, and basically they are just wildly ridiculous, and they were not taking implants out of patients because they were just all crazy. Their implants were causing a problem. If that's where we were, that's not where we are as it relates to the subject, and that's not fair to patients. Patients didn't need the implants in the first place. They chose to have them. The surgeon chose to put them in, and they surely have the right to not have their implants anymore if they want to. I think the question is about the capsule, as Dennis mentioned, and having more information to help guide us when we think taking a capsule out could be really deleterious to that patient, to be able to have that conversation. My patients have been very reasonable. I mean, you have an occasional crazy one, but that's not somebody who probably is going to come to see me in the first place anyway. I'm very frank with them. We don't entertain the concept of an en bloc resection. We don't dictate an en bloc resection, nor do we do an en bloc resection. As Dennis and Pat both said, there's a lot of reasons why you see one of these patients, and they have textured implants in place, and we're thinking about mitigation of their risks of ALCL possibly. They have inflammation going on. They have a mouse-shaped pocket anyway. There's reasons why you would want to take the capsule out, but when it's like Dennis made the perfect example, a saline implant with extremely thin, wispy capsule, and you're going to go in and promise you're going to take it out with the capsule all as an en masse resection. That's craziness. What I tell all my patients is that, and I think maybe it's the most important, is that I believe them and I care, and I will always be honest with them. Things that they may want to hear or not want to hear, but I'm going to be honest with them, and I'm going to continue to learn myself and research more so I can be a better doctor for them in the future. And a paper like this that Caroline and Pat put together helps us in doing that and being better doctors to them. So I have a very open mind about this with my patients. I keep them safe. I will definitely address those issues if I need to. Yes, Dennis.
Yeah, and what I wanted to ask Pat, if he could explain a little bit better. I mean, all of us get the idea of a partial capsulectomy and possibly leaving a little bit behind against the chest wall. Of course, what was called in the paper was the clean capsulectomy, which is what I think most of us probably can do most times, is front and back, just get it out, whether it's done with the implant inside or not. But how did the idea that an en bloc capsulectomy is something that's going to be required to treat this disease? Because en bloc is a cancer terminology that removes taking a normal, by definition, it involves taking a normal bit of tissue from around a mass to be certain that you got it all out. Well, that's what a complete capsulectomy does. Why do we need to even consider the term en bloc capsulectomy?
That first was written about by Dr. Susan Kolb in a book in 2008. And she's a plastic surgeon in Atlanta who wrote I forget what the book was called. It was like something like How My Implants Are Killing Me, or something like one of those, the terrible problems with implants. And what she said in her book was that failure to remove silicone, leaving it in the body, silicone is toxic. And even a small amount spilled into the chest cavity. She said, how close is it to the heart? It's right by your lungs. And failure to remove all the silicone and all the silicone that could be in the capsule, it could lead to persistent symptoms. The interesting thing is in the breast implant illness groups, this really became very popular in around 2016, which was the same year the World Health Organization designated breast implant associated ALCL as the fourth type of anaplastic large cell lymphoma. And the recommendation for treatment of ALCL is en bloc capsulectomy. So I think that with these patients, they conflate ALCL and BII sometimes, and they think, well, to cure yourself of this lymphoma, you have to take the whole capsule out. So it probably should be the same thing for patients, for our systemic symptoms. I think that's the origin and my interpretation of where this has come from. And now it's really, in the hardcore groups, they really, you'd think they would be happy. Our first paper showed that these patients' symptoms improve after implant removal, and they don't need an en bloc capsulectomy. That should be good news for the breast implant illness patients, but a lot of them aren't happy about that.
This also gets conflated with the idea of silicone, as you just mentioned, that there's as many or more of these cases of BII in saline breast augmentation. And although they have a silicone shell to their implant, there's a lot of people who very much confuse that and believe that this is related to silicone implants and to silicone and the whole idea of Asia syndrome and silicone as an adjuvant to the development of these symptoms. And yet many of these cases are saline breast augmentation.
Yeah, in our study that was published in December, 64% of our BII cohort had saline implants and 90% were smooth. Our non-BI cohort, we had more gel and more textured implants. So this is a disease of both saline and gel, smooth and textured.
And is it correct, looking at the papers and the literature, that there's really no data so far to suggest that capsulectomy will be associated with improvement in the symptoms?
But there's no published literature that there's Dr. Lu Jing Feng published a paper in the Annals of Plastic Surgery where it was, I think 700 patients that underwent en bloc capsulectomy and had symptom improvement, but there was no control group. And there were no patients that didn't have an en bloc capsulectomy. So it's, you have no controls. And the follow-up on that study at 6 months was 5%, as opposed to our study where we had 98% follow-up at 6 months. But their symptoms do improve. And we had patients that did not have total capsulectomies. And we photographed the implants, the capsules, to photograph what type of capsulectomy was performed. And I've been asked, well, what percentage was left behind? It was different on all these patients, and we didn't tell, it wasn't like it was randomized to who was going to get an en bloc, who was going to get, because they would never have gone for that. But the BII patients, they will have surgery for, if they don't get better, they'll go back for retained capsule surgery. And I had a patient come in with, her breasts were destroyed from an en bloc expert surgeon taking her back for a retained capsule. And she came to me because she wanted a mastectomy, because she said her breasts were so terrible and there was no way to fix it short of a flap. And she was 70 years old, didn't want to do that. And she showed me the picture of the retained capsule that she had. It was the size of my thumbnail, and they think there's enough toxins in that capsule to cause their symptoms. And we just had our second paper, which is a heavy metals analysis, which was just accepted by ASJ actually a week ago. And in that paper, we sent 200 capsules, 50 patients, 2 from each patient for heavy metals analysis. And we did find metals in the capsules of all patients in both cohorts, but there was less than there was in the breast tissue of women who never had any implanted medical device. So, and there are also some confounding factors, tattoos, smoking, gluten-free diets exposes patients to arsenic. I mean, we're all surrounded by environmental toxins, and that's how they get into our tissues. And in this paper, our conclusion was, the presence of heavy metals is not an indication that to require a capsulectomy in patients with systemic symptoms.
So if I'm reading this correctly, then that's fascinating data, but an en bloc capsulectomy, taking normal breast tissue out with the capsule is getting awful close to just a mastectomy, is it not?
Some of these patients it is. And the patients you see that have problems are the ones that have subglandular implants, minimal breast tissue, previous periareolar incision, and they undergo these en bloc capsulectomies, and they're left with fairly significant deformities. Now, would they have just removing their implant? Maybe, but at least they have some movement of the tissues that they won't get the adhesions that you see in a lot of these patients after a capsulectomy. And, for the surgeons that are advertising as en bloc experts, the en bloc is not a term that should be used for benign procedure. It was initially described by Dr. Halstead in the 1880s for breast cancer. And we'd really like people to get away from using that term and use a total intact capsulectomy or total precise capsulectomy, referring to removing the entire capsule around the implant rather than calling it en bloc.
And
the other capsulectomy issue that I've had, I'm sorry, Brad, go ahead.
No, go ahead. No, go ahead. Go ahead.
The other discussion that I've had with patients in my own practice has been some of them will be quite forceful in demanding that the entire capsule will be removed with the breast implant inside.
Yeah.
And I've tried to explain from an exposure standpoint that is difficult in many instances and essentially makes no difference whatsoever. Could you comment on that?
Yeah, that goes again back to Susan Kolb's book, where she said, and they feel like if you disrupt the capsule at all, the toxins from the implant are going to get out and get into the body. So they really feel like you have to remove the implant and the capsule together so as not to expose the body to any more of the toxins. So we're hoping, with our study, the third paper, which we're actually writing now, looks at bacterial and fungal DNA analysis, histopathology, cytokines, and toxins, enterotoxin antibodies, to see, what other toxins could there be in the capsules as potential causes of these symptoms. And, but, convincing these patients, the other thing, our first paper showed that with these patients, their primary source of medical information, 66% of the BII cohort was social media, whereas the control groups, it was less than 5%. So it's kind of cognitive bias for they're finding the answers that they want to find. And it goes back to this, you have to remove the entire capsule so as these toxins don't get into the rest of the body. But they do consider it acceptable as long as the entire capsule is removed.
I think that the clear thing here is for surgeons, and I think they're missing the point, that there is no data, there's no science to back it up. And so it's actually malpractice. There is no justification for doing one of these procedures. And it's not just that you could get a pneumothorax or something worse that happened. but you leave them very, very deformed in a situation where there's just absolutely no justification. There's no science for it. And as I always say, in a world where it seems like science doesn't really seem to matter anymore, because social media seems to be more important, as physicians, we're obligated to stick to the science and know that doesn't mean we can't be listened to it. It doesn't mean we can't work with the patient to give them a procedure that they will feel comfortable with. But at the same time, leaving them with severe deformities in their breast for no really good reason, without them really understanding it, isn't fair either. And so I would never want a surgeon to dictate that they did an en bloc resection on one of these. Dennis?
Yeah, I was just going to say, I was going to highlight, doubling down on that with what both Brad and Pat said. And I think, Pat, you described it very well in the article. It's important to listen to these people for sure, because as I've heard you say, sometimes they do present with an actual medical problem.
Mhm.
And some of these symptoms they're having could be a pituitary tumor or some sort of I think in paper you had a liver tumor. There could be the first signs of a real leukemia, for instance. We have to remember that we still have to be doctors, and sometimes these symptoms can be the first presenting complaint.
Dr. McGuire, 'cause I get the sense that most surgeons are not either referring or sending labs themselves. And I think you said that you can do either one based on your comfort level. I mean, what do you recommend for most surgeons, to refer or to send off their own labs?
I think it's always, if they have a primary care physician, somebody that they go to send them back to their primary care for a workup. It depends on their symptoms. If they're just tired and gaining weight and they sound like menopausal symptoms, then you say, go back to your gynecologist, make sure you have anything done. Many of them come in with full lab works. They come in with their whole lab been done, everything's been finished. But the ones that come in that are like, these emergency BII cases. I saw a young girl yesterday who she's 29 and suddenly had all these different symptoms, and ended up she had gotten on one of these sites, and she wanted surgery tomorrow. She's had no workup. And I don't think there's anything medically wrong with her. I said, no, you need to go back to your doctor. You need to get a workup. And I think at least if you're going to operate on these patients, check a CBC, get a comprehensive medical panel. They need, breast imaging is indicated. If they're due for a mammogram, they need to get a mammogram. And I ultrasound these patients, patients with gel implants before surgery, because I don't want any surprises. I don't want to get in there and have a seroma I didn't expect. Or if they have a rupture, I'd be more likely to do a total capsulectomy than I would for an intact implant as well. There's a paper in January in ASJ that showed the complications of capsulectomy, reviewing the Cosmetistry data, and the risk of implant surgery, revisional surgery with a capsulectomy had double the risk of surgeries done without capsulectomy. So that's significant, it's a significant reason to really consider. This is not completely benign surgery. The most common one they reported was hematoma, but you can have, the MD Anderson reports with their en bloc capsulectomy for ALCL, a 5% pneumothorax rate. That's not insignificant. So these are not benign procedures, and you can talk. The real difficulty is you talk to these patients and I explain the side, tell them, I've done this study, we have all this information. There's no scientific evidence that you need your entire capsule removed. And they're like, oh, yeah. But could you please do it? And I think a lot of these patients have significant anxiety disorders. And when you show them that picture of the implant and the capsule removed together, you can see their anxiety melt away, because they're absolutely convinced that the implants do have these toxins in them. And if you don't remove the capsule, their symptoms aren't going to go away. So it's kind of a conundrum, because, you can explain it to them all, but they still say, yeah, I understand that, but I really want my capsule removed. And we really have to try and get them away from that.
What's interesting. Go ahead.
Sorry, I have just a timely question from the audience from Dr. Lawrence Italde. Just as you were saying just now, Dr. McGuire, he mentioned these studies are establishing a framework that extensive surgical capsule surgery is not a definitive treatment for BII symptom relief. How do you recommend that we manage these patients when they push back against the data?
Yeah, I think that's an individual decision. I always tell them if I get in there, sometimes it's really easy to take a capsule out. You get in there and it's an easy dissection. You know, if they're subglandular, yeah, I'll tell them, if you let me make a big enough incision, I can get your capsule out. Or if they're having a mastopexy at the same time, you have a lot of exposure, I can get the capsule out and I know it makes them feel better. But I tell my patients, if I get in there and this is a wet toilet paper, I'm peeling off of a wall under the muscle, saline capsule, I'm not going to give you a pneumothorax. I'm not going to I had a patient that insisted on it when I first started seeing these patients. I took her whole capsule out and I ended up taking the periosteum off of her rib, and she has chronic rib pain now. Now, she thinks it saved her life, so she's not complaining about it, but I can't do that. And I tell the patients that I'm not going to do that to you when I now have scientific data that shows that it's not necessary.
What's surprising, what's exciting, about these patients, and that we don't even know why. I've never had a patient, I ask every patient, I've never had a patient who regrets having their implants taken out. And they almost all report some symptom relief. I can only think of one person who has said, nah, not really. But the vast majority of them feel better, live a better life afterwards, at least initially. There's a few that are really honest and they will say that, maybe they were initially hopeful all of them would go away, but a lot of them went away. So I think for the surgeons is to know that, these patients, even if it's psychological, are they feel better when their implants are out for whatever reason that is. And also when you discover an autoimmune disease or send them off of that, they then often believe that the implants triggered the autoimmune disease more than, they have an autoimmune disease. That's the reason for their symptoms. Their implants aren't causing them. So you should be prepared for that as well, too.
Thank you. We have Dr. Mark Jewell on as well, who wrote a great commentary to this article. If you have any thoughts, we'd love to hear from you.
Hi, Mark.
I think you might be muted.
You muted yourself again, Mark. Hang on.
I'm unmuted now.
Yeah, there you go.
Good. Hey, Patty, Caroline, great article. I enjoyed writing the commentary on it. And, again, I think the biggest thing here, we have to be compassionate physicians. We have to listen to these people and be engaged with them versus being dismissive. That helps a lot. That gives them the security and trust that's necessary in a relationship like this. And again, if they want their implants out, sure, take them out. But, again, emphasize that there may not be symptom improvement. And certainly, Patty, you've got that website you tell people about that talks about explant regret. So, again, the more they're educated about it, both the downside of it and the upside, I think the better off we are. But, again, I think it's unconscionable to promote a cancer operation for a benign condition that we really can't define all that well, even at this point, in our, knowledge base of this disorder. But congratulations. It was a great article, and I feel honored to write the commentary.
Thanks, Mark. There is, like Mark mentioned, that the BII social media groups, the largest one has over 150,000 members. But there's another group called Breast Explant Regret. These are women who had implants removed without symptom improvement. Some are left, they put pictures of themselves up with really horrific deformities. And that group went from 3,000 to 7,000 members in the last couple of months. So, there are a group of women with explants, and you want to read interesting blog. Lisa Souter has a very good blog on breast implant illness on her website. And she's retired plastic surgeon and has had a lot of interesting things with this stuff.
Yeah, some of these people actually will come back and say, I want my implants back. Thank you very much, and I can't live without it. So, you have to listen to them again too.
Yeah, I've had 5 patients of all the BII, and I do quite a few of these BII patients. I've had 5 come back wanting their implants replaced. I make them wait a year before to do it to make sure they're not going to change their mind again, and they do fine.
So following up just a bit on what Brad had just said a minute ago, And you pointed this out as well, Pat, that a lot of these patients will get better for reasons that we just can't explain. Nothing that we can find laboratory wise or heavy metal wise, but they will get better, feel better after they have their implants taken out. But they really haven't been followed long enough. There's not a real good data set out there that goes beyond 6 months or a year or 2 years. Because as we know, there can be a transient, perhaps even psychologically mediated. So yeah, I'm so glad I did that. I was right. I had needed to get my implants out. But then we don't know what's going to happen when you talk to them at 2 years or 3 years or 5 years. And so that's a data set that we need to try to get if we can.
I think Dennis raised a good point here, because the placebo effect of surgery certainly is well documented, and maybe longer term data will give us more insight there.
Yeah, Pat, why don't you or Caroline, either one, you guys talked a lot in the past before, maybe it's not in the publication exactly, the sort of anxiety disorder that you guys found in your data, there's the psychological component to this, in such a way, and I would just say simply that maybe the breast implants themselves are creating anxiety, and when the implants are removed, the source of anxiety is lessened unless they get better. But you guys looked at that in your studies, right?
Yeah, we used, we did a kind of detailed symptom survey plus PROMISE, which is an NIH validated patient reported outcome measure. We used it for anxiety, sleep disturbance, fatigue, and cognitive function before 3 to 6 weeks, 6 months, 1 year post-op. And these patients were way above, that's against the population of the United States. And they were way above the two control groups, our non-BII implant cohort and our Mastopexy cohort. There was no statistical difference between those two groups at baseline. And the BII patients' anxiety decreased significantly on the PROMISE data at 3 to 6 weeks and 6 months, but never normalized. They always stayed a little bit above the average for anxiety. So I think anxiety is a big component. The question is the chicken versus the egg thing. Did they have an anxiety disorder and their implants exacerbated it, or do they have, did the implants cause them to have anxiety? And Bill Adams is starting and Dave Turer is starting a prospective study on women with augmentations to follow them to see, if they had anxiety before, they're more likely to develop some of these symptoms afterwards. And I think that's what we need. I think there was some lost opportunity in the post-approval studies on the breast implants to track these kind of symptoms and things and long-term follow-up on the patients. Yep. Caroline, you have anything you want to add? She's on there, but if she's paying attention.
We can get back to her. Denise, do you want to tell us about the poll questions?
Sure, yes. So it seems as though 100% of our audience routinely counsels their patients seeking breast augmentation with implants about BII. So this certainly does help all of us in terms of young plastic surgeons or even people who are experienced and been doing this for 20, 30 years as to how to counsel these patients. And then about 90% of us have patients who have had their implants removed because of BII, and the majority of those patients ask for on-block capsulectomy. And I think that's the next big debate, is what to do with the capsule, because taking an implant out, easy peasy. If someone wants it out, you take it out. But the workup, the counseling, the capsule, all the little details. So I'm really excited to see the rest of all this work and hopefully have a better practice for myself.
We just submitted an IRB for a study on these patients where we don't remove their capsules and do the same symptom surveys and PROMISE post-op, so we can see if no capsulectomy gets the same symptom relief. The problem is going to be finding patients willing to do that.
Mm-hmm.
I wanted to follow up on something that Brad said, and something I've noticed in my own practice is that while you do get the occasionally really distraught patient, been on the social media groups, fairly high strung, perhaps, demanding en bloc capsulectomy and whatnot. That's not really the most common type of patient I see. It's kind of like what Brad said, pretty common for them to come in. You know what? I'm done with my implants. So they were good for when I was younger. I just as soon have them out so I don't have to worry about them anymore. What can you do once they're out? And so I've got a burgeoning little practice of implant removal in a very healthy way, followed then by fat grafting and mastopexy and breast lifting and
Yep.
just sort of cosmetically just improving the shape of the breast that's there. And that's become kind of a subset of this whole discussion.
Brad and Dennis, you're like experts on mastopexy. Do you do a mastopexy at the time of removal?
Most of the time, if they have tissue.
Yeah, that's the key, is they have to have tissue.
Yep, absolutely. Especially, and then if you're doing your mastopexy, if all you do is deepithelialize the pattern, if you're not, listen, don't go home Monday after the ASPS meeting and try to do some fancy flat rearrangement on one of these people that you saw in a 10-minute talk. This is not the time. Just deepithelialize the skin and sew it together. And
Good advice, Dennis. Otherwise, it's going to be a catastrophe, you know?
what's the old saying? Most complications occur
Yeah.
the Monday after a major meeting.
That's right.
Yep. And even beyond that, what's interesting with me is that as I've gotten better auto-augs and everything else in mastopexy, I find myself more often than I would have 5 or 10 years ago doing mastopexies with auto-augs or fat grafting or other things that I have available now, and not using implants with my mastopexy as often as I would have. And when I published back in 2013, about 75% of all my mastopexies got implants. And now it's at 50% or maybe even a little bit less now. I don't know if that's because I've gotten better, but I think it's because fat grafting has become more acceptable and we have other ways. And, if you can give somebody a beautiful breast and they don't have to have implants that they manage the rest of their life, I think that's a great thing.
Interestingly, a lot of my breast implant illness patients say they've always hated their breast. From the time they had their initial surgery, they hated the result. And a lot of them, they went in for a mastopexy and they were talked into you won't be happy unless you have an implant. So I think they went in with a they weren't sure, they, rushed a decision. A lot of them were in bad relationships at the time and the ex-husband pushed them into it. And I think it just starts a bad situation and they really associate negative things with their implants. And that's where, listening to their stories and talking to them, they're not crazy patients. I saw a patient last week that she said she saw another guy, and as soon as she mentioned BII, the guy said, "I won't touch you." And I actually really like these patients. I think they're usually pretty intelligent. They're, they can be demanding and crazy, but the vast majority of them are really lovely people who are just frightened because they have a lot of symptoms and nobody can tell them what's wrong. And if you're willing, like Mark said, you're willing to listen to them and, and be sympathetic to them, that's the best way to get the foot in the door. And then they'll trust you to do what's right for them. And they won't care if you don't have the full on-block capsulectomy because you were honest with them from the beginning.
Yep, that's exactly right. I had a surgeon who sent me a note last week. I know him. He asked me lots of questions about breast. And he said, "I want your opinion. I had a lady come in with symptoms of BII and she thought her hair loss was from her BII. She finally stormed out furious. So clearly the conversation didn't go as great as we've all described here. And his office staff thought he should call her back and try to make amends. And he said, but I'm not in the habit of calling back crazy patients. And I wrote back to him, I said, okay, well, right away, if you perceive them as crazy, your staff's probably right. You need to call them back. I have a good sense of what that conversation was like. And that you can't, he said, I think I need to educate myself more about BII. I think that happens more than we understand with surgeons seeing these patients for that. And I think I think in a real way, they just don't know. They haven't kept up with what's going on in this world. They come to it from a very naive place and they don't know how to address it with the patients. So I think things like this journals are great to be able to get in front of more people this information.
Can I ask Pat a quick question?
Yeah, go ahead.
Pat, sometimes back to the discussion we were having before, I take an implant out of somebody and say it's been a significant volume, so I don't have a lot to work with. And I'm concerned that they're going to have a deformity no matter what I do, no matter what kind of lift I do, fat grafting. And I just in the back of my mind say, my goodness, if I could just put a little 125 cc smooth, round saline wafer in there just to give me something to fill out that skin envelope, I could prevent a really horrific deformity from happening. Do you think you'll ever be able, you and Caroline and others will be able to demonstrate data that says that a smooth round saline is not even remotely part of this discussion, or can we say that now?
The majority of our patients the BI patients in our study had smooth round saline implants, 66%, or 64%. So that makes it difficult. Although there was a paper in the 90s by Wally Peters where they removed implants for systemic symptoms. And it's one of the papers that the BII people often talk about. They said, oh, it showed the patient's symptoms removed. What's rarely discussed was 40% of those patients actually had a saline implant replaced after there, and they had the same symptom improvement as patients who had who did not have their implants replaced. So the other thing what we were hoping to find is maybe this was a biofilm. If that would be easy then. If this ended up being a biofilm, they have a subclinical infection, great. We take their old implant out, wash it out, put some betadine or phase 1 in there and put a new implant in and they're better. But we're in the process of analyzing our PCR data for the implants, and we're doing diversity scores now on it. So we'll see if that ends up showing anything.
Dennis, in that same vein, I have told patients who kind of really are afraid they're going to regret not having implants, and or once we see them and they have what you just described, I do talk to them about the possibility in the future when it's available of a Motiva implant. And I talk to them about the fact that surface topography has shown that the immune response to it and a low immunogenic response implant may be something that could be in their future. We need more data, but I just wanted to give them a glimmer of hope that there may be some new devices, some new things out there that may be possible for them in the future if they feel like they may want to step back into a breast implant and stuff. So I think it's in that same vein that you were describing, a small little wafer saline implant. I think that
I've asked in the international groups, Brad, about Motiva implants. It's the fastest growing in the BII groups, probably because it's the fastest growing implant being used. It's not the implant, it's the patient's body's reaction or their particular reaction. I think we've seen a change from 4 or 5 years ago. There were kind of two camps: either all these women are crazy, or the people taking advantage of these women. The en bloc experts, and you have to have a capsulectomy, and the Instagram posts of their capsules and all that. I think we're getting more people to the middle, that we need to listen to these women. They're not crazy, and we don't need to do extreme surgeries on them. And I think that's a huge step forward for both us, for all of us as surgeons, and for the patients. Mm-hmm. Dennis?
I was just going to ask, I know we're getting close to the end of the time here, but Pat, if you could look in your crystal ball, I would say that the response to this in 2022 has been remarkably different than 1994. And these patients have been taken seriously. We've had discussions like we're having tonight, where we have to respect their opinion and take their symptoms seriously. And for gosh sakes, they've been given a booth at our national meeting, and they're allowed to come to most of our presentations. And they've given presentations at our meeting. I mean, we've really worked hard to engage with these women and these patients in the most positive way that we can. If this works out based on studies like yours and others, that we just can't find anything. And it might just be that these are a self-selected group of people that are particularly prone to anxiety or anxiety-related disorders that could be playing a role in what's happening here. Is that going to be an acceptable outcome?
It depends on who you talk to. If you talk to the hardcore groups, it's not, they will never accept that. Implants are toxic, and, we're educating people, and we're actually seeing some of the advocates come around. They're open to the data. They're open to listening, but there's still some that will not listen. They're happy we're doing research, but they don't like that we didn't show en bloc capsulectomy, which is really deep in their dogma, is necessary.
Well, I think it's this with the patient checklist, but with the fact that, like every surgeon said in the survey, that they're talking at least about this concept of BII before patients have augmentation. I think it'll be interesting to see, because now you're selecting a group of people who, even being told this ahead of time, the anxiety group, it may click them out of it and not even consider implants. It'll be interesting to see how that changes the next 10 years for these people who are, because the average time is maybe like 6 or 7 years to get these symptoms, that at 10 years, now that we've consented in a different way, and the patients that are getting implants already know that there's some people with these symptoms, will that change the paradigm? Will this group of patients have less complaints of BII or not? And I don't know the answer to that, but I think that would be very interesting.
So we have at least 3 audience questions for the 3 of you to tackle in 5 minutes, if you don't mind.
Okay, we have one comment from Dr. Ruiz Trevino, who's on the call, and he says that he's been treating BII patients for about 5 years now, and anytime they've accepted a psychiatry consult and started SSRIs, that they've completely resolved. So I don't know if you guys have experienced that. I don't know if Dr. Ruiz Trevino, if you have any comments about that briefly.
I'm not surprised.
Yes, we're not surprised, because a big stigma of these patients is that they are under a very large stress. They are very stressful. So we can add to their stress some surgeon-made deformities when you take capsulectomies, total capsulectomies with very thin tissues. So if it is a big component of stress, if you manage stress, many of these patients could improve. Anyways, about our surgery, if we operate on them or we decide not to, it's a very good area of opportunity to do more research, the stress.
Yeah, very interesting.
Yeah, Dan Law, who was one of our authors, who's a rheumatologist, said for these chronic pain syndromes, fibromyalgia, chronic fatigue syndrome, the treatment is not medications, it's not surgical, it's usually biofeedback and behavior modifications rather than surgical or medical interventions.
Thank you. Yes, it's a very good answer. Thank you.
I think Denise might have frozen. Can we take the question?
Sure.
Hey, I can just jump in, everybody. Thank you so much for this great talk. So I'm Tony Yoon, plastic surgeon in Detroit. So I do a lot of explants, nowhere near as many as Pat does, but and one of the issues that I find is I have a patient who has had implants for a long time. The breast tissues are relatively thin. You take the implants out and they're left with a deformity where the tissues actually may look fine in the OR, but when they come back after a week, they have drains in, they get these unnatural indentations at different parts of their breasts. And oftentimes they don't seem to go away with time. Do you have any suggestions on how you treat that or prevent it? I know one doctor said she just doesn't even put drains in her patients, and she lets them have a seroma and waits for the seroma to eventually resolve.
Yeah, I sit the patients up, because what they look like laying down and what they look like sitting up are 2 different things. And the other thing that happens, I think their natural inframammary fold, especially the patients that had their fold was lowered a lot. When they take the implant out and you're kind of guessing where the fold's going to be, that can cause some of these deformities. So those are patients that might be better to delay a mastopexy or, tell them the removal. It could be. The other thing that I do is when we hook the drain up to suction, we look and see what it looks like. And if it looks odd, we take the drain off of suction and just leave it to gravity. And also make sure when the dressings are put on, they're not put where they're folding the breast tissue and skin on top of itself, because that tends to contribute to these deformities. And I have my nurse call them the next day, have them take off their bra, show her a picture, FaceTime, or send a picture, whatever, to make sure. Because I think if you catch those things early, they're less of a problem than before. But you can predict it's not a lot of breast tissue, usually, thin capsules, total capsulectomy, a previous periareolar incision are the ones that seem to get the worst deformities.
Patty, sometimes I use, the silicone-faced foam that we use for liposuction. We'll put that on to support the skin. And that seems to hold things in place nicely too.
Yeah.
But the bottom line problem, Tony, is that you've got a mismatch between the surface area and the volume.
Yeah.
Mhm.
So what you're seeing there is, almost an unrecoverable situation.
Yep.
You either have to tighten the skin envelope at that moment, or just let it set and come back later, release the scar, and then do your mastopexy at that point, maybe with a little fat grafting. But it's not like you're going to magically make that go away by putting a drain in or not putting a drain in or whatever. So
yeah,
it's not
my
your
problem
fault.
has been the patients who had originally a very small footprinted breast that's over the top of this new augmented breast. And when you take it away, you have, like, as Dennis mentioned, all that stretched skin, but you still have this native original mass of breast tissue that's very central, almost like if you think about like a tuberous breast, and it's sitting there, not really knowing what to do with that sort of volume in the middle of all this sort of extra skin. A mastopexy doesn't in of itself resolve that issue. And I think those are, in my mind, sometimes the most challenging to deal with.
Do any of you doctors often do a masto at this time of the explant, or do you usually delay it?
I always do it if there's enough tissue.
Yeah, if they don't have tissue, it's not a good idea. But if they have any tissue, I will do a mastopexy at the same time. But if they're like paper thin, no tissue, then those can end up with pretty significant deformities.
Yeah.
Thank you.
And I think for our last question, Brian Lee is wondering if anyone has any thoughts on methylation detoxification pathway as an etiology.
Yeah, a lot of these patients talk about MTHFR as potentially, they don't detoxify things as well. And after hearing all of these patients, I actually had checked myself for MTHFR genes, and I'd had 23andMe done, and they'll send it off somewhere for like $10. And I'm homozygous for like the 3 worst ones you can have.
Oh, really?
Like, oh my God, like C6777, and I forget what the other 2 are. So I called a hematologist at WashU, and I was like, oh my God, I have this, I have MTHFR, homozygous, the worst ones. And she's like, we don't even test people for MTHFR anymore. And as long as you take folate and methylated folate and B12, you're fine. So I think it is not as much of an issue as is brought up. And a friend of mine who's an OB said they don't even check it in pregnant women anymore.
Yep.
Are there any other comments or questions from anyone?
Thanks for setting all this up. This is really fun.
Thank you. Thank you, guys.
Well, thank you. I just wanted to close by thanking Drs. McGuire, Dr. Hammond, and Dr. Calabrese for really excellent, thoughtful discussion and many teaching points. Thank you to Phaedra, and we'll see you all back here in May for our next journal club, which will be hosted by Ryan Austin and the Next Generation editors. And thank you for joining us, everyone. Have a great night.
Thanks,
Good to
Mark.
see you, Mark Jewell. Good to see
Good to
you.
see you.
I know.